Okay, good evening, everybody. Welcome to this another session of 53rd Comprehensive Course on Echocardiography. We are from Jorop Institute of Echo, Ultrasound and Vascular Doppler, Delhi. And we have come a long way since our beginning. Today is 12th of August, 2026, and we're going to talk about cardiomyopathies. As you understand, we have many accreditations apart from International Society of Cardiovascular Ultrasound, Alabama. We have an accreditations from Parul University, Vadodara, as well as Guru Gobind Singh IP University. We can boast of saying that we have been the longest running training program in India for more than 25 years. Thousands of people have attended these programs, and some of them have risen to a directed non-invasive cardiology in major cardiovascular hospitals. Our aim is to make next program better than before. That's our aim is. We have a widespread participations from varied countries around the world. And we started this program in April 2000. You can understand this is more than 26 years of its existence. Today, we are going to continue with the topic of cardiomyopathy. That's part 2. And we have the elegant speaker, Dr. Hansa Gupta, who's the Director and Chief of Non-Invasive Cardiology at Para Hospital, Gurgaon. And on top of that, she is a President or Chairman Scientific Committee of the upcoming Echo Asia 2026 in October 26 in Gurgaon in Leela Ambience Hotel. With these few words, let me hand over mic to Dr. Hansa Gupta to continue her presentation on restrictive cardiomyopathy. And then, if the time permits, I'll show you some cases of right-sided cardiomyopathy along with a live demonstration of certain DCMP, how come, and many other more. And welcome, Dr. Hansa. It is all yours to take over.
Thank you.
And you
Good
can share your
evening.
slides now.
Yes, sure.
Your slides are seen. Just you have to press your wine button.
Yeah, the slide shared because this.
The slides are seen. You have to press your wine button, enlarge them. That's all. It's everything is fine.
Actually, that wine button is not seen because of
It's
this
there.
bar. No, it's there, but this other thing is covering it. Now just
Just
it's
move the bar.
gone. आ गया. It's okay.
Yeah, perfect.
Is the
Please
full
go ahead.
screen? Yeah.
I'll just go to mute, and I'm there sitting over here.
All right.
Thank you. Take care.
Okay,
Bye-bye.
friends, let's start again. Move to the third entity. As I told you the other day, cardiomyopathy actually presents in 3 phenotypes. We discussed dilated one, we discussed hypertrophic, and now the third is restrictive. There may be several etiologies, but the presentation will be in the form of restrictive cardiomyopathy. So let's see, and let's revise that cardiomyopathy is a primary disease of the cardiac muscle. So here we find the restrictive ventricular physiology in the presence of normal or decreased diastolic volumes of one or both the ventricles. Just remember this; these are the basic criteria when you wish to fix an etiology into some diagnosis. Normal systolic functions of the ventricle and normal or increased ventricular wall thickness. And can you see here? Okay. So the ventricles are all normal, usually normal, not normal in the sense, normal, not normal in the functioning. The systolic functions are normal. Okay. So restrictive cardiomyopathy, it represents an extreme form of diastolic dysfunction. And by now you must have understood about the grade 3 diastolic dysfunction, which is the extreme of the spectrum starting from the normal, grade 1, 2, and 3. What does grade 3 show? The E is twice than A, more than twice. Okay, it is a very tall, very short DT, deceleration time of small A wave and a very tall E wave. So here, let me just give you a pointer that if you come across this kind of pattern in a young individual of 30 years old who is a good runner, normal person, and you find this, do not label it as restrictive. That is because of the extremely compliant LV muscles, which lead to sudden filling of the blood from atria to ventricles. I hope you understood. It is generally said that when you find this kind of pattern in a person less than 40 years of age, you must again see the associated findings to label it as a restrictive pattern. So coming back to restrictive physiology, we have this kind of pattern in which is the extreme form in restrictive cardiomyopathy. So what is this grade 3 dysfunction? The compliance has just gone. So the muscles are stiff, they are rigid, they are not relaxing, and so they are not able to take up the blood from the atria and pass it on forwards. And the pressures inside the left ventricles go high. So this is what is the physiology. Okay. So there is a relaxation impairment, the muscles become stiff. And now see what has happened here. This is the TDI velocity. Your E prime, A prime, everything has gone down. Okay, because of these stiff, non-compliant ventricles. Now, let's understand the pathophysiology, which will help you understand the entire gamut of this type of cardiomyopathy. What happens? Stiff ventricle. Remember, there is an impedance to LV, left ventricle filling, pan diastolic, not just early diastolic, late diastolic, it is throughout because the muscles are stiff. So it is a pan diastolic impedance, which leads to increased ventricular pressures without increase in diastolic volumes. This will give a back pressure and the atrial filling pressures will increase, leading to pulmonary and systemic congestion. And the resultant symptoms, because the patient may present with fatigue, weakness, exercise intolerance because of the poor cardiac output. Sorry. And these symptoms are because of the back pressure, the pulmonary dysfunction. And the lungs are congested, and so patient can't lie down, is orthopnic most of the times. Now see this is the kind of image when you see you're doing an echo, the LV looks normal, the LV systolic functions are normal, LV doesn't look dilated, not looking full, but the LA is looking dilated, RA is also mildly dilated. So the abnormal diastolic function is leading to LA dilatation and to the entire pathophysiology of restrictive cardiomyopathy. So as we have understood in the other two phenotypes, that in hypertrophic cardiomyopathy, the muscles are thickened, resulting into all the problems. In dilated cardiomyopathy, the systolic functions are not abnormal and the muscles have dilated. And what is happening here? The muscles of the LV apparently look normal, their systolic functions are normal, but the LA is dilated. So when you are handling a patient of dyspnea or exercise intolerance and you find on echo that the LV looks normal, so generally beginners, they just focus on the LV. So you will probably dismiss this case as a normal case, and you may not even think about restrictive pattern or restrictive cardiomyopathy. So all of you just remember, whenever the LA is dilated with a normal LV function, this should come into your mind. Such a patient may also present with atrial fibrillation. Elderlies may present like this. So there may be in cardiomyopathy, the atrial myopathy is there. We need to differentiate with restrictive cardiomyopathy of the LV. So atrial fibrillation, a new atrial fibrillation setting in, you must do an echo and the echo will tell that the LA is enlarged. Why is the LA enlarged? Because the LV is stiff. It's transmitting its pressure into the LA. So RCMP is the only one of the many restrictive heart diseases. What does that mean? The hypertension can also make the ventricles stiff. Hypertrophic cardiomyopathy. So every cardiomyopathy has a pattern of progression. So as the disease grows older, this may lead to burnt out HCM, which presents like a dilated cardiomyopathy. HCM may also progress through a phase of restriction, right? So that is why it is mentioned here that hypertrophic cardiomyopathy also may sometimes present with restrictive pattern, and eventually it may burnt out and present as dilated cardiomyopathy. And as I said, restrictive heart disease of elderly. So in elderly, the fibers become stiff, and this may also be the reason for restriction. And other is the primary cardiomyopathy, which is the cause of restriction. We will discuss what are the different etiologies which lead to this kind of presentation. Then the chronic constrictive pericarditis is considered to be the most important differential, which we will discuss in the last, is usually asked in the questions. And also when clinically you need to differentiate, this becomes an important entity which you should know that how to differentiate it with the restrictive cardiomyopathy, because there are many features which they share, which they have in common to share. All right, so I was talking about the causes. Just a brief description. I'm not going into the detail. There are so many of them, but the common ones which you can come across may be myocardial or endomyocardial. In myocardial, what can you have? The non-infiltrative one. The one which is most common is idiopathic or diabetic familial. The infiltrative one, we will discuss about amyloidosis, which is nowadays considered to be the most important cause of restrictive cardiomyopathy. Then you must have heard about sarcoidosis, Gauchers. Then the storage disorders like hemochromatosis, iron storage disorder, or the Fabry's disease. So these are some of the very, very important identities you should remember: idiopathic, amyloidosis, diabetic, of course, sarcoidosis. You need to have a little differential. Earlier, biopsies were tried to differentiate the cause, but nowadays, with the availability of cardiac MRI, it becomes the uh, investigation and the imaging procedure of choice, which can help us differentiate the cause of RCMP. Of course, with the help of echo, we can reach a conclusion, but the etiology is very difficult to identify. So MRI, cardiac MRI has a lot of features which can differentiate these individual diseases. Coming to the other category, this is the endomyocardial causes, in which we have EMF. All of us have heard about it. The hypereosinophilic syndrome, carcinoid, radiation, anthracycline toxicity. So always remember, I think I have a slide on radiation also. So nowadays, because of too many cases of oncology, a lot of radiation is being used, and hence the radiation related toxicity leads to these kind of problems. And as doctors, we should be aware that radiation can be one of the important causes. So again, as I said in the previous class, history taking is very important, ECG is very important, and of course the symptoms and everything. And the you're reading this as hypereosinophilic syndrome. How will you prove that? You need to have a CBC with you to understand that the eosinophilic levels are too high. Now let's understand what can echo do to diagnose and prognosticate and understand the disease. So let's revise. Restrictive LV physiology, but LV function is normal. All right, so there is a abnormal diastolic function, but normal systolic functions. How to approach? First, to determine whether echo features are consistent with restrictive heart disease, and then try to establish the etiology. As I said, first you will try echo, then various blood tests, and then finally, of course, um, cardiac MRI is opted for. Nowadays, biopsies are usually not done to reach a diagnosis. Okay, so let's revise. I've written this again. Normal sized ventricles, normal EF. There can be a hypertrophy of both LVH, RV, and LV. So do not dismiss this as that, like, this is not. But why is there a hypertrophy? We will see. This is not a true hypertrophy. This is endocardial deposition, which appears as hypertrophy. Yes, there can be again a pseudo hypertrophy noted in amyloidosis, where you can get an appearance of thickened LV and RV. There is a significant grade 3 diastolic dysfunction, biatrial enlargement like an owl is also called as an owl appearance. You can have mild MR and TR. The PA pressures are, of course, increased. You may find clots in atrial appendages because of the enlarged and increased pressures. Then I wanted to also say, yes, the IVC will be dilated. So all these parameters are actually confusing with the constrictive pericarditis. So patient coming with dyspnea, and apparently on first, like, you apply the probe, you find LV to be normal, LA dilated, IVC dilated. Think about restriction as the possible cause. So this is how you can do, keep ruling it out, but have it in your mind that yes, this is also a kind of identity which is not rare. Again, these are the grades. You all have learnt about it. So just briefly, I would like to tell you that this is the grade which actually defines restriction. Restrictive cardiomyopathy, such a tall E with a sharp deceleration time, small a. This is in the mitral, when you put a pulse wave Doppler on mitral inflow, just at the tips of the mitral leaflets. Now, coming to the pulmonary venous flow. So these are three parameters, importantly, which help us defining the diastolic function of this patient. What are those? Just for revision's sake, mitral valve flow, pulmonary vein flow, and the tissue Doppler. In pulmonary vein flow, can you see this? The systolic is higher, and now the systolic has become so low. So this is also a typical feature of advanced diastolic dysfunction. See the atrial reversal. Why is the atrial reversal going so high in the pulmonary vein? Because there is, when the atria is contracting, it has no, the blood has no place, not the place, in fact, has no gradient to move towards the LV. For any movement of the liquid or the blood, we need a gradient. Because of the high LV filling pressures, there is hardly any gradient. And so instead of moving forward towards the LV, the blood moves back into the pulmonary veins, and because of which you find a deep AR reversal, atrial reversal. Can you see this, how it is normally found and what has happened to it? Okay, so I think it is more than 30 centimeters per second, then it is considered to be high, and it is for a longer duration also. So when you divide, when you subtract this duration from this duration, if it is more than 30, this is 35, this velocity more than 35, and the difference more than 30 is considered as grade 3 diastolic dysfunction and is suggestive of many problems. Now, what is happening on tissue Doppler? Everything has gone down. Okay, E prime has reduced. Okay, so not just when I was talking about this pattern in a young individual, these things will not be there. E prime will not be low, E prime will be very robust. So all the findings have to be there to actually mark your patient as restrictive, as having restrictive physiology. So this is the pulmonary vein Doppler. Where do you keep it? In the superior pulmonary vein. Okay, you keep your pulse wave here. And then you get this kind of systolic, diastolic, and atrial reversal. Yeah, AAR, atrial reversal minus A. What is this A? This A is when we take the mitral inflow pattern. Okay. So when the difference is more than 30 milliseconds, then we consider it as to be very significant. Again, IVC is dilated, non-collapsing. This all depends on the treatment, on the stage of the disease. It's not necessary that it is always non-collapsing. It all depends on how badly the patient is congested. So just a reminder of 2.1, more than 50% collapse on sniff. See, inspiration is better. The sniffing is better than inspiration. What is this sniff? Just, can you see me? Simple little sniff helps in differentiating, whether the IVC is collapsing. So collapsing means that there is a normal pressure and it's not congested with blood all throughout, and the blood is moving forward and backward. And then accordingly, you can adjust your right atrial pressures. I'm not going into the details of that. Now, what is this? This is important, very confusing. So we need to understand the hepatic vein, but I'll just give you brief uh, uh, understanding of what the hepatic vein Doppler is. My suggestion is that keep practicing even in normal people, that how does hepatic vein Doppler normally looks like. What are the various waves you keep seeing in your patients? And it's always good to put a respirometer on the patient, which will help us to understand the inspiration and expiration. And even if you don't put it, at least you know that the chest is going up and down, which will help you understand. But of course, an ECG is mandatory. Now, what happens in hepatic vein? Hepatic vein, uh, so the blood comes down away from the probe. And so you are finding all your major flows down. Why down? Because the flow in hepatic vein is going away from the probe while when you are interrogating. So we generally choose the vertical hepatic vein. When so normally the flow will go to IVC and then to the RA and RV, and after into the pulmonary arteries. So what happens? Systolic forward flow, systolic reversal, which is very small, sometimes not even seen. But yes, there is a small reversal. You should know about that. Then this is diastolic wave, forward wave, and a diastolic reversal. So this is the main one, the diastolic reversal, when the ventricles are relaxing. Then when there is a back pressure, then the diastolic reversals go. This is what is, discussed when you differentiate between constriction and restriction. Now, try to carefully understand and listen to me what I'm trying to now tell you. See, what happens in constriction. Okay, I think we'll talk about this a little later because it is again going to come. Let's not discuss it here. Okay, again, this is very intriguing actually, so everybody wants to know about it. Just remember, in constriction, the blood flow is very dependent on the respiration. See, inspiration and expiration both, they change the flows. Whereas in restriction, you take constriction as a rigid box where everything is equalized. So one compartment, the blood goes, the other has to compromise. When the blood goes in the other compartment, the right compartment has to compromise. So in constriction, since it is a rigid box, it is very, very dependent on respiration. And so you have heard that the tricuspid flows, when you put a pulse wave Doppler and you record the tricuspid flows, you'll find that there more than 40% of variation with the respiration is there in constriction. Whereas in mitral, more than 25% is considered to be abnormal. So, and similarly, in expiration, there is a significant diastolic reversal. Significant diastolic reversal. But this is happening in inspiration. Inspiration is what? It's not a rigid box. It is the disease primarily. So pan-diastolic, not much of respiratory difference. If you're not finding too many respiratory differences in the various flows, just think towards restriction. When there are too many respiratory flows, it is more towards constriction. I hope you are able to understand, but do go back and read about it because it is a little complex thing, but it is basically the pathophysiology, if you understand, will help you. See the this is the normal pattern, how the E behaves, okay, and how it is becoming sharper here. DT is less than 160. So all these things should be in on your tip to basically reach a conclusion. Okay, how do you differentiate with hypertension? It's predominantly a disease of left side involving involvement of both ventricles is uncommon. Mitral annular tissue velocities markedly impaired in RCMP and not so much in HHD. Hypertensive heart disease will have this kind of severe diastolic dysfunction only in very late stages. So this is how you can differentiate. Okay. Let's move on. Amyloid heart disease is the most common cause, as I said. So most commonly you find AL variety or the TTR variety. Nowadays, medicines are available. However, they are very, very expensive. Hence, diagnosis becomes our responsibility that we reach some diagnosis. Here, the amyloid deposition among normal myocytes, no myocyte hypertrophy per se is there. In between the myocytes, there is deposition. All right, so there is a thickening, appearance of a thickening. But the myocytes per se are not hypertrophied as found in hypertrophic cardiomyopathy, where there is a sarcomeric mutations, gene mutations. I think these are also the same thing we are talking about. Right. Here we will understand.
Dr. Hansa, I'm sorry to just show some slides of images, like these
I'm
are
just coming to the image
template of the
also.
images because they'll be able to understand much better with that.
Now we will have only images. Okay, after this. So I was just trying to prime them with this. So you can see here that this is a speckled appearance here of an amyloid patient with hypertrophy also here, right? So this is an amyloid heart disease. See this? Now also remember here that whenever you find a pericardial effusion in hypertensive patient, not hypertensive patient, a hypertrophied patient, always think that there is a possibility of amyloidosis. So pericardial effusion points out towards amyloidosis. And of course, when you do strain imaging, I don't have that image, but if you do a strain imaging, you get a cherry top appearance wherein the strain is, it spares the apex actually. And now what is this? This is the 555 sign found in amyloidosis, where you have all the TDI velocities which are less than 5. So even the systolic, there is a systolic blunting because the functioning is less, the E prime, the A prime, all are less than 5. So this is called as 555 sign of amyloidosis on TDI. Definite diagnosis is biopsy, but then MRI helps. So again, towards the endomyocardial disease, you have Loeffler's and EMF, and Dr. Rakesh wants me to show you images, but just understand that there is a lot of necrosis and thrombus formation and infiltration, because of which there is a lot of deposition at the apices, because of which there is a blunting of the apex. Now, how does that happen? Let us see here. See this is two eosinophilic myocardium, and see this, the pink one. Okay, this is the pink one. These are the depositions. So this is how it looks like. And see, both the atrium are so dilated. Okay, I'll show you further. In endomyocardial disease, see the RV is almost obliterated. Here you can find both because of a lot of infiltration, thrombus. See this RV? And the here, this also, the LV function appears normal, but there is a thickening and apical blunting because of the fibrotic endocardium. Here, the endocardium, we have discussed amyloid as myocardial etiology. Now we are talking about endomyocardial etiology. So Loeffler's come into one of those. You can get thickened fibrotic endocardium affecting the valves as well. But always remember, see, both the atriums are dilated. You are getting regurgitation also. See the apex, which may be missed. Apex never looks like this. And if you may ask me a question that before you ask me, I'm trying to tell you that you will always find a difference fit. A difference, like, is it apical cardiomyopathy? In apical cardiomyopathy, apex is never obliterated. It becomes a spade-like thing. You will still be able to see the apex. It is thickened but not obliterated, unless until there is a thrombus on it. Okay, so LV is involved in both in 40%, but both can be involved in 50% cases. And there are fibrous lesions which involve the endocardium as well as the valves. Again, see this, how thickened the entire myoendomyocardium has gone and leading to the dilatation of RA and LA. See, dilated LA, dilated RA. Okay. And we get a lot of thrombus in such cases, both in the ventricle and the atrium. See here, the arrow is pointing towards this. This is all deposition of the fibrotic material due to inflammation and necrotic material deposited here and in RV. RV is almost obliterated. And in such cases, you will find a lot of back pressure in IVC leading to dilated IVC. See here, towards the arrow. The arrows here. This is all showing deposition and obliteration of both LV and RV. See such a bad RV obliteration. So what is this going to cause? The RV, basically the chamber size has become less. Okay, what will happen? This will lead to back pressure in the IVC and the entire system will get congested because the RV is obliterated. When you do a fluoroscopy, you'll find a box and glove sign. Okay, because of this obliteration of the LV. It's looking like a box and glove sign. This is the apex. So just keep watching it, because whenever a case comes, you should know in your mind that yes, this is a possibility. Because what your mind knows, your eye will see. Okay, as I said, cardiac MRI is very important. It helps us in differentiation of constrictive and restrictive. And so let's discuss. Dr. Rakesh, I have only these many images, and I think I'll have to, ye thoda constriction I have. Okay, so I have to differentiate between the restrictive and the constrictive pericarditis. This is a primary muscle disease. This is a pericardial disease, and both result in restrictive physiology. We have understood here the myocardium is stiff, but the pericardium is normal. And reverse is here. The myocardium is normal, but the pericardium is rigid, non-compliant. So again, the history is important. Did the patient undergo any cardiac surgery wherein the pericardium was opened up? It may be a bypass, valve replacement, any other cardiac surgery. The patient has received any radiation. There is any history of tuberculosis, right? So all these things have to be asked when when you see that there is a dilated IVC, bouncing septum. Now, no significant ventricular interdependence because the heart is not beating in a cage. No respiratory variation, no septal bounce. Here we have marked ventricular interdependence since the heart is encased in a rigid box, and to keep the pumping on and keep the blood movement on, the ventricle has to keep shifting towards right or left depending on the chamber which is getting filled. So that leads to a lot of respiratory variations. Now this has refused to work, and you see the shudder. Okay, this is a very characteristic shudder of the septum, which is called as septal bounce, double component due to alternate changes in RV and LV pressures. So M mode is very important. However, septal bounce is very, very clear sometimes when there is an extreme case. This may also happen in other cases like left bundle branch block, post-surgery. So it's all, these are the reasons. Now you must understand this carefully. So ventricular filling is restricted pan-diastole. E prime is low, E upon E prime is abnormal. Why is that so? Because the pressures are high, leading to this abnormal. So E we know from mitral inflow pattern, E prime from TDI. If it is more than 15, it is a marker of raised LV filling pressures. Then here, due to cage, ventricular filling is restricted only during late diastole. When the expansion has to be maximum, it restricts it. So what happens, E prime almost invariably here is more than 8 because of the septal bounce. And the E upon E prime is normal because there is no muscle disease, because this is actually false kind of situation which is happening here, because the E is high and E prime is also high. This color mode, this I'm skipping. We have large atrias, atrial enlargement is less, RV pressures are much more, and longitudinal strain is reduced as the myocardium is diseased, which is normal here. Here, torsion is abnormal. So this is just to increase the number, but these are the prime features. Diastolic dysfunction is in absence of pericardial disease, AS, hypertension. This we have discussed. E prime is low, non-dilated ventricles, thickness may be increased hepatic vein reverse flow with inspiration, and which is also not much. Biatrial enlargement, increased pulmonary artery systolic pressures, dilated IVC, normal systolic function, normal pericardium. Okay, so I think that's it with the restriction and constriction. So primarily, you have to understand that no one comes with a diagnosis. You have to understand that if the patient comes with dyspnea and bad exercise tolerance, and you find the IVC to be dilated, septum is bouncing, a lot of respiratory variations, hepatic vein expiratory reversals, or maybe you are finding that with the respiration the diastolic reversals are too high, then in those cases think about constriction and then take the history accordingly. But when these respiratory variations are not there, and you find that the E prime is low, the muscle is diseased, and there is so high a restriction of physiology, you should think in terms of RCM. So that is what I was supposed to tell you. And then rest, you can keep, revising this, and you will gradually, this is actually thought to be a difficult topic, but it is not actually when you understand the pathophysiology. So my request is that whenever you read this topic, do go through the pathophysiology of constriction first, and the topic will be very easy. Thank you so much. Any questions? Happy to answer.
Thank you, Hansa.
Yeah.
Let's take some questions from audience. Anybody like to ask some question? Please raise your hands. Dr. Vinash, go ahead.
Good evening, ma'am, and good evening, sir. What are the pitfall in diagnosing constrictive cardiomyopathy and same as in restrictive cardiomyopathy?
What do
Can
you
you
mean by
just
pitfalls?
Sir, there are so many septal bounds. Sometimes we confusing that there is a jerky septum like this. So I just want to know what are pitfalls.
No, you wanted to understand what exactly the features which differentiates constrictive versus restrictive cardiomyopathy. Correct.
Yes, sir.
So the first of all, the most important thing of this restrictive versus constrictive pericarditis is like annulus reversus. If you look at restrictive cardiomyopathy and constrictive cardiomyopathy, constrictive pathology, the E prime septal and E prime lateral, they have got a very strong relationship. Why? In restrictive cardiomyopathy, the E prime of septal would be smaller and the E prime lateral would be taller. That's one. Then E prime of both septal and lateral would be smaller in restrictive cardiomyopathies. On the contrary, if it's a constrictive pericarditis, constrictive physiology, the E prime lateral would be smaller as compared to septal pathology. Correct? That's first and the foremost important thing is. And second, E prime dash is tall because there is no restriction for dilatation. There's only obstruction for lateral expansions. That's in constrictive pericarditis. So in constrictions, as far as relaxation is concerned, that's very well there. But restriction to relaxation is there in lateral annulus. So if you look at E to E prime ratio average, it will be large in case of restrictive cardiomyopathy and it will be smaller in constrictive pathology. That's one issue. Second important issue is there is an interventricular dependence in constrictive pericarditis. What is interventricular dependence? Heart is enclosed in a shell of a pericardium, which is thick and calcified and does not let heart to expand itself. So what exactly happens when you breathe inside? The inspiratory flow velocity of tricuspid valve will go up. The interventricular septum will bulge toward left-hand side. And on the reverse side of mitral side, the flow velocity will reduce. There is significant respiratory variation is present, more than 35% in both mitral and tricuspid in constrictive physiology. Second important thing is when you relax, you breathe out. So interventricular septum will bulge towards right-hand side so that the blood is being pushed from atria to ventricle, ventricle to aorta. So flow velocity across mitral valve will increase during expiration. And that process, when expiration happens, there's no way to blood to go outside because IVC is already plethoric. The blood will go into hepatic vein. And that is what is said like first beat after expiration, there's a hepatic venous reversal flow. Correct?
Correct.
Respiratory variation, septal bounce, interventricular dependence, and on top of that, this first beat of expiration reversal will give you a fair good idea. Look, we are dealing with constrictive pericarditis. Third important thing is get your CT scan done. If your CT scan shows significant thickening of pericardium, the fair chances is you are dealing with constrictive pericarditis. And last, one more is look at an RV strain. In constrictive pericarditis, RV strain is preserved. In restrictive cardiomyopathy, RV strain is reduced to a large extent. These are the four very important signs to differentiate constrictive versus restrictive. I was about to come down to those points because you asked me in between. I started working on that. And give me some time, I'll come back to certain live demonstration of these physiologies. Okay?
Okay, sir. Can I ask one more question?
Yeah, you ask as many as possible, but speak a little louder or come closer to your mic, laptop.
Sir, there is respiratory variation across tricuspid valve and mitral valve flow. But also there is respiratory variation across on tissue Doppler also. E by E
Respiratory
prime.
variation across tissue Doppler would be less because respiratory will not affect the myocardium. Respiration will affect flow across the valves, not the myocardiums.
Then when we are measuring tissue Doppler septally prime or laterally prime, there should be also variations. Which one measurement should be
If there is a
taken?
variation, always measure end expirations.
Okay, sir. Thank you.
Give me some time. I'm going to show you some cases of that same. Okay, Dr. Rupali, go ahead.
Good evening, sir. Good evening, madam. We can see atrial fibrillation more commonly with restrictive physiology.
Perfect.
Sir, is there any specific reason or
Very specific reason for restrictive physiology is what is restriction is. Let's go back to the basics of restrictions. Some hindrance to flow of blood from LA to LV. Correct. What is that hindrance?
myocardial stiffness?
Correct. You got the perfect point, Rupali. I appreciate your knowledge because as we age over a period of time, so my LV becomes stiffened. So it does not relax properly. When it does not relax properly, what will happen to my LA?
It will
It
enlarge.
start dilating.
Dilating.
The flow pattern from LA to LV, which was normal earlier, tall E, small a, start reversing to small e, tall a. Over a
Yes.
period of time, my LA pressure keep on building. My LV is not going to relax. So my LA pressures, which were there by small e, tall a, which was approximately 10, now they build up to 20 or 15. Let's take 15. And that's what in diastology means. From normal diastolic flow pattern, we are going to grade 1, grade 2 diastolic dysfunctions or grade 3 diastolic dysfunctions. If there's a grade 3 diastolic dysfunction, means LA pressure basically are very high. When these LA pressures are very high, which are not able to release themselves because of a stiffened LV, and on top of that, majority of these people, they develop hypertension, they develop diabetes, they're obese. So that adds more insult to these LA pressures. When they add more insult to their LA pressure, this dilated LV starts stretching towards pulmonic veins. And whenever they start stretching toward pulmonic veins, your patient gets atrial fibrillations.
Okay, sir.
And this is very common, like there's a terminology which is known as heart failure with preserved ejection fraction. You must have heard this terminology very often nowadays. What is that heart failure with preserved ejection fractions? My LV function is perfect. So is my LV function is perfect in restrictive cardiomyopathy. My LV becomes stiffened because of hypertension. So my LV pressures start building up. And these pressures, they reflect to right hand side and the patient is in congestive heart failure. So all these things together, even heart failure preservation fractions, you can predict these people, how many of them are going to get into atrial fibrillation tomorrow. So it's not basically something else. It's a stiffened LV, which is leading to raised LA pressure and all those consequences of raised LA pressure. I hope I'm able to explain these things to you.
Yes, sir. Thank you.
Anybody else? So, Dr. Hansa, thank you. We can stop sharing your slides. Let me start picking up a few things for them. I've collected certain important cases, like many more of them. So let's pay thanks to Dr. Hansa. Dr. Hansa is there or not?
I'm there, very much there.
All right. It's always I say it's always a blessing to listen to your voice.
I don't
So
know. You're as fresh as you're starting the day.
yeah, I'm starting my day. It's only 10:30 right now.
Yes. So it's like inspiring, but I am.
You change your battery from Novino to this. What do you say? The share. This I forgot the name of this cells. Duracells.
Duracells. Correct.
They live longer, 3 times longer than the normal batteries.
Yes. We'll try doing that.
Yeah. So you can be with us and whatever,
Yes.
like you just listen. And
Yes.
I'm going to show them a couple of examples, live examples of all of these things, like whatever we learned in last 2 days.
Yeah. That would
And
be
a
great.
couple of example of right-sided cardiomyopathy. They are very keen to look at those kind of things. So
Yes.
just allow me so that I can share those, open my slides.
Yeah.
Look, where like these things is they charge my batteries, like they don't discharge me basically. When I'm teaching, like it gives me a lot of positive.
Yes. That's why you are able to teach, na? Because it needs a lot of motivation and encouragement.
Yeah, because these are the things which makes you a lot of happiness. Like it's not like that. You're just teaching like anything.
Excuse me,
It
sir.
is very unusual to, find this in today's time. Nobody has time and energy to teach the beginners. So I think this is a blessed lot. I must tell you that Dr. Rakesh is there to keep teaching you anytime and every time, 365 days available. It is like, beyond my imagination how he does it. Difficult for
You,
me
you,
as
you
well.
don't have to imagine anything. Forget about
Yeah.
it.
No. I must mention, because I also admire you for this quality of yours. Because in our times, there was no one to teach us. We used to learn the difficult ways.
All right, Hansa, can I take us? Somebody was trying to ask some questions. Somebody was asking. Please go ahead and ask the question.
Sir, excuse me, sir.
Yeah, please go ahead. He has asked you to.
Yes, sir. Yes, ma'am. Sir, my question is, how do we classify Dressler syndrome in which type of cardiomyopathy?
Dressel syndrome is nothing like a post myocardial infarction issues, and we, truly speaking, I don't think like we classify this in any kind of a cardiomyopathy.
Okay, sir.
And is this something like you develop a chest pain soon after your myocardial infection? And if at all the heart dilates, it could be because of that myocardial edema. So we don't classify this into any single variety. It could be just a swelling of a heart which happens when you are immunodeficient.
Okay,
And
sir.
the classical part of this particular Dressler syndrome is like it always gives you a hint, like this person who was doing fine after the interventions or after any surgery, he started becoming breathlessness and the LV function started deteriorating. Got my point? So if I have to put this into together to one of cardiomyopathies, I can only say the person behaves like a dilated cardiomyopathies. But truly it's not, because we don't put anything in Dressler syndrome in cardiomyopathies. And second important thing is, the most important thing in Dressler syndrome is we always have a pericarditis along with it. And majority of these pericarditis, they present with a very small amount of fluids, very tiny amount of fluids. The most important of this, these syndromes are, you are able to hear the pericardial rupts. So if I have to really say that this is what it is available, I'm not truly like in which category I'll put it, but I'll only say that this is one where if you can have an edema of the myocardium, that's one, but the majority of time is the edema of the pericardium, which produces a painful chest. Patient become dyspneic and may have some kind of another things like where the pericardium starts getting inflated. How much the myocardium is involved, I'm not really sure about it.
Okay, sir. Thank you.
All right. So let's go to this particular phenomena. Look, hypertrophic cardiomyopathy, Dr. Hansa showed you very good examples for hypertrophy. Let me show you an example for hypertrophic cardiomyopathies. Look at this is a static images. If you look at carefully, this is plaques view. I hope you are able to see my slides. This is plaques view, this is septum, and this is posterior. If I take an M mode or cut, the septum is as thick as the posterior wall. There is no asymmetrical septal hypertrophy. Correct? And same thing over here. Same thing in M mode over here, because M mode become very useful in this subset of populations. And the most important thing in this patients is, like, you do not have any LVOT gradients. In contrast to hypertrophic obstructive cardiomyopathy. And what are the features of others? We should have a systolic anterior motion of mitral valve leaflet. Look, this is E wave, this is A wave of mitral valve. DE excursion, EF slope, and then A wave. So we do not have any systolic motion. Look, this is systole. So we do not have any systolic motion of the anterior mitral valve leaflets. Then look at this particular phenomena. This is apical hypertrophy. She was trying to show. Look, apex is obliterated not because of the tissue. It is obliterated because of the presence of thickened apical myocardiums. Now this is a 3-dimensional picture. You can see an apex over here. And what you will find in ECG? Left ventricular hypertrophy pattern. One AVL, lateral leads. Now you can see much better. You can see a very well clear apex. LVH, and if you have restrictive cardiomyopathy, you will not find any significant difference in ECGs. So this is like we have taken a section across this. This is 9 segment sections. Look, this is apex. I can see the apex. There's no obliteration out here. This is basis. This is thickened sigmoid septum. Look, this is just a basal anterior septum which is thickened. And it's inconsequential. So what is most important thing is in hypertrophic cardiomyopathy versus non-hypertrophic. In non-hypertrophic pattern, there is multiple varieties are present. The uniform thickness of the myocardium all across. No evidence SAM, no evidence septal posterior wall ratio, no evidence of dynamic LVOT obstruction, no evidence of MR. Various reasons for hypertrophic cardiomyopathy, non-obstructive, hypertension, aortic stenosis, chronic kidney diseases, coarctation of aorta. And if you happen to see this kind of pathology without obstruction, look at the obstruction distal to aortic valve. Or look at the kidney conditions. All right. And then move to hypertrophic cardiomyopathies. Now look at this hypertrophic cardiomyopathy, which is obstructive. There are three features of asymmetrical septal hypertrophy. SAM, systolic anterior motion of mitral valve leaflet. Third, dynamic LVOT obstruction along with mid-systolic MR. Now look at this picture. Now this is systole, this is diastole. This is mitral valve AML, this is PML. Look carefully, this anterior mitral valve is moving towards septum during systole. And you cannot find better than anything in M mode. If you can draw an M mode across mitral valve, that is the best thing you can do. You can see really the systolic anterior motion of the mitral valve leaflets. There's just a cursor across this mitral valve. Correct? Now this is broaden up. Now this is mitral valve in diastole. Now this is systolic anterior motion, means the AML is moving towards septum to produce obstruction. Same thing. Now, whenever this I should have, now look at carefully. What do you see in this patient? You see 2 times movement of the AML. Look, just focus on this particular valve. It's not moving 1 time during diastole. It's moving 2 times during cardiac cycle. This is only 1 cardiac cycle. Look at very carefully. Just focus. Arjun ki aankh only on AML. And no, what happens? When this AML moved in systole towards septum, the mitral valve will remain open, will give you mid-systolic MR. When this moves during systole, it's producing LVOT obstruction. So what you will find? You will find dynamic LVOT obstruction. Dynamic means rapid, slow deceleration, acceleration time and sharp deceleration time. In aortic stenosis is short acceleration time and sharp, slow deceleration time. Reverse. In LVOT gradient, the gradient gradually built up and sharp deceleration time. And look at this inverted key slope shape pattern. Now these are 3 patterns together. This is aortic pattern and this is inverted key slope shape pattern. Look at this pattern over here. Slow acceleration, sharp decelerations. Now look carefully. If you can really look, concentrate on this picture, take my words, you will get the best answer. There is a turbulence in LVOT and similar at the same time, we have MR. Now look at this picture very carefully. Beautiful picture sent by one of the cardiac technicians. Let's come to 3-chamber view. Give it a breathing time. Look, there's a dynamic LVOT obstruction in this patient. Now, this is diastole. Look at this. Look at this movement over here. So let me go back to my picture. So you will have turbulence and LVOT at the same time MR. I'll show you one more picture like this. So these are the features of obstruction, asymmetrical hypertrophy, forget about small LV cavity. Systolic anterior motion, dynamic LVOT obstruction, mid-systolic MR. And if you can't see this at dynamic LVOT obstruction, ask to do a Valsalva maneuver. Don't use nitrate at your levels. If the BP falls, it becomes very catastrophic. And these people, they have a progeny. You find many people in their family suffering from the same things. And they don't present like, they present with arrhythmias, syncopes, irregular rhythms. And you can find them at any age. If you happen to find one outcome, Always try to scan whole of the family of hypertrophic obstructive cardiomyopathies. And it is said, I don't remember how many years, they should be followed because they can develop over a period of time. In our country, I always say that if I'll say 1 year, they'll come after 3 years. There's no guidelines for them. This is nothing of your level. I want to show you some more of hypertrophic cardiomyopathies. Now look at this image. Very carefully look at the turbulence at this point and look at the MR. Is a systolic turbulence along with MR. Apical and should not like there's evidence of a caudal SAM also. Large cord which gives rise to systolic anterior motion and dynamic LVOT obstructions. This is a variety of dilated cardiomyopathy. Look, LV is dilated. And look at this spongy myocardiums. Hundreds of names have been given to them. And every now and then their name is changed by some other person sitting in Western world. And what exactly? It's a sieve-like pattern. Look, the blood is as if it's moving inside into the myocardium. This is a congenital variety. Majority of these people, they do not live beyond 3rd or 4th decades. Look, this is 3-dimensional picture. Can you see the sieves, burrowed endocardiums? At one time, they was considered as thrombies, maximum macrothrombies. And this is bilateral. Look at the LV as well as RV. And what category this patient they belong to? Anybody? Raise your hand. Dilated cardiomyopathies. And this is non-compaction. It means the segment which is compacted versus non-compacted. This is compacted segment. And wherever these things are seen, these are non-compacted parts. These non-compacted parts, they are 2 times of this compacted parts. So ratio of non-compaction, like you can measure this with, versus the compaction, it's more than 2:1. All right. And these people, they behave like DCMP. 4 pillars of a treatment. I say 5th today. I always say 1, diuretics, sacubitril valsartan, beta blocker, dapagliflozones, MRAs, and last is virasaguat. Avinash, go ahead.
Sir, how do we measure compaction and non-compaction?
Very simple to measure. Go to short axis view at the papillary muscle level. Look at the segment where it does not have this spongy myocardium. Suppose this is a segment which has got spongy myocardium over here and no sponge, like this is compacted segment. This is frozen up segment. This part is frozen up. So this is compaction and this is non-compaction. So this is almost 2 times of non-compaction than compacted segments.
Sir, measurements should be taken at the same place or different?
Same place. Go to short axis view at mid level, and then you can do it.
Thank you, sir.
All right. She was talking about restrictive cardiomyopathy. What is restriction? Restriction is the flow from LA to LV is restricted. So if it's not hypertrophic, there's so many things which can produce restrictive cardiomyopathies. Endomyocardial fibrosis, Loeffler syndrome, idiopathic, infiltrative disease like amyloidosis, sarcoidosis because of radiations. Some storage disease also produced. So instead of myocardium getting stiff, There's some deposition happens in those myocardiums. Patient will come with what? Patient will come with right side biventricular failures. LA pressures are also raised, RA pressures are also raised. And look, this is a patient somebody, Dr. Rupali was asking me. Look, this is the classical patient of restrictive cardiomyopathy. The patient is in atrial fibrillation. And look, LV, RV size, they are normal. LA, RA, they are large in size. If the rhythm is normal, we have ratio of 2:1. Tall E, very small A. If the rhythm is abnormal, then we only see E wave. And then we utilize E prime septal with a ratio of more than 11. So remember a simple principle. If it's a restriction, normal LV-RV size, dilated LA-RA size. And you put a Doppler flow pattern across this. Rhythm is normal, then you tall E, small a, ratio more than 2:1. And if it's irregular, E to E prime ratio should be more than 11. Look carefully now. Look at the both LA and RA, they are dilated. This is a patient which presented with restrictive cardiomyopathy because of pyopericardium. And they'll have all kind of things, MR and TR. Look at tall E wave is almost 96. Small E wave, only maybe 3 or 2. So 96 divided by 3, it'll be 32. E to E prime ratio is 32. In case of constrictive pericarditis, this E wave would be tall. E prime would be taller. It will not be smaller. Here, this could be taller, but this will be taller here also. So the E to E prime ratio would be very small. If you happen to see E to prime ratio of 4, 5, or 6, then your ear should start ringing. Why this E to prime ratio is 5, 4, 5, 6? Look at the volumes. LA volumes is 72 ml. Even if the body surface area is 2 divided by 72 divided by 2 is 36 ml. Large, more than 34 cc per meter body surface area. Forget about that. That's what I was trying to show you. Dr. Avinash asked me this question. E to E prime ratio, annulus reversus, hepatic venous reversal flow, then interventricular dependence and calcium all around the heart by cardiac CT scans. And like many features like amyloidosis is quite common. If somebody has seen the Mackinus Gold, I don't think anybody have seen the Mackinus Gold. When a Gregory Peck gets up in the morning and see in the valley, all valleys brightly shine because the gold is reflecting back. The rays from the sunlight are reflecting back from the gold. So if you happen to see a picture, let me just show you a picture. Look, everything would be thickened. Now look, this is a classical picture for amyloidosis. Thickened myocardium, thickened septum, thickened valves, LV-RV, very good contracting. LA-RA, look at the RA is bigger than LA. And there's small amount of pericardial effusion. And what is the difference if this hypertrophy is present? I can say this hypertrophy is because of left ventricular hypertrophy. But ECG will differentiate. LVH will have left ventricular hypertrophy because of hypertension, or other reasons will have one AVL and laterally changes. Here you can find changes, but not significant. Look at the smaller one, pericardium. Look at the speckled appearance of these myocardiums. Tall E, small a, restrictive filling patterns. Deceleration time, this is when we were talking in 2000. We never used to have a tissue Doppler. We were using deceleration time. Less than 130 was prognostic of type 3 diastolic dysfunctions. What she was trying to mean, endomyocardial fibrosis means apexes are obliterated. I'll show you a couple of pictures. Today, I'm not going to show you anything else. Look, this is a classical picture of ARVC. LV is clean shaven. RV apex is replaced by fibrous tissues. Lot of fibrous tissue over here. And this sometimes gets dilated. The ratio of RV versus RV becomes more than 2:1. So I'll come back to this ARVC again. And the most important classical sign is there's virtually equalization of pressure between RV and RA. The gradient is very small, 30, less than 30 millimeters of mercury. So these are things which presents with RV, arrhythmogenic RV. Let me stop sharing over here and go back to some classical examples, more of them. Nothing like it. I'm not going to teach you theory anymore, but certain important sign which you should understand when we are dealing with this.
ARVC.
Look at this ECG now. Very classical ECG. Let me focus. This is V1. We just pass it off as RBB kind of a pattern. This is RSR pattern. But this T wave or this R pattern has got bifid waves, and which is known as epsilon waves. And next time you happen to see a ECG, just look at these epsilon waves. And these people, the number of times they present with malignant ventricular tachycardias. Younger generations. How the picture looks like? Now you can see the picture. This is short axis view at the level of papillary muscles. Look, these are both papillary muscles. This is LV. This is interventricular septum. This is mild pericardial effusion. Look at this RV. RV is heavily tuberculated and it appears to be bigger than LV. This is inflow view. RA, RV. Look, heavily tuberculated. Now look at this. This is apical ballooning has happened in this patient. And now you can see much better. Look at this heavily tuberculated RV. And if you put a continuous wave Doppler across this, because they have a significant TR, but the gradient is only 16 millimeters of mercury. These people, they do not have a problem with this RV. The problem with them lies with this malignant tachycardias. So dilated RV-RA without thinning. If thinning happens, it becomes Uhl's anomaly. Reduced RV systolic function, severe TR with no significant gradient. LV-RV ratio more than 0.5 means 2:1 if you reverse it. Large tubercular bands filling almost full of the RV. And this picture present with number of times they present with in younger populations. I'm not going to detail. This is what I was trying to say. Reduce RV two-dimension strain. Not at your level, but it's okay. So if you happen to see this kind of picture, an epsilon wave, think of ARVC in younger populations. lot many varieties. I'm not going to go details for all of you because this is level 2, level 3 when we have to talk about that levels. Let's show you something more than this. All cardiomyopathies.
Excuse me, sir.
Go ahead, Dr. Rupali.
Sir, one question about this ARVC.
Go
You
ahead.
said it is commonly seen in younger population.
Correct.
Mostly it is congenital.
Correct.
So we have seen many sudden cardiac deaths in athletes or marathon runners. Sir, what is your experience about? Is this the reason in such patients they are having
Could
sudden
be.
cardiac?
I can't say no to it because it could be reason. But the reason of sudden cardiac death in athletes nowadays after this COVID is lot many difference are there. I don't say like alone it's there. So there are
Okay.
various reasons. I'm not going to decide about those reasons over here. But athlete heart could have various other reasons for sudden cardiac death. All right. Let's see one more. Look, this is very faint picture. I'm not really sure how many of you can see it. You see a turbulence in LVOT, you see MR at the same time. Now you see this large AML, large PML leaflets as if they're crossing like this. Normally they're not like this majority of times. Let's see three-chamber view now. Now with three-chamber view, you see that leaflet is coming into the LVOT. This one. Now see this. What did we do? At the beginning, we were not able to see any gradient across this LVOT, no turbulence. We subjected this patient to limited exercise, 124. Please do not do at your levels. See significant turbulence at LVOT and mid-systolic MR. Now look at the gradient, almost 8 meters of flow velocity. And nothing was seen during resting period. You don't do it. I'm warning you again and again. What you can do is just a Valsalva. Hand grip methods. Don't give sorbitates. So now you can see a very beautiful. Let me just do something more for you. Now you can see better. Turbulence over here and mid-systolic MR. Now see a gradient of almost 7 to 8 meters. If not 7 to 8, at least 6 to 7 meters. And look, it's slow acceleration time, sharp deceleration time, inverted key slope shape और खुकरी shape. जो गोरखास और खुकरी रखते हैं बिल्कुल डिट्टो वैसी है. And the problem with these people are they die because of a sudden cardiac death, and they have to have AICD installed. ARVC, AICD. These people, AICDs. So this is how my Hokam presents. Look, I was not able to demonstrate. This is resting phase. This is after stress. This is 135 heart rate. This is 88. They play at the same frame rate, but the heart rate are two different. Let me show you some more examples. Just give me some time. It's opening up.
Sir, any side of cardiomyopathy, put AICD. Right side or left
Right side
sided?
cardiomyopathy is ARVC. Left side cardiomyopathy is hypertrophic osteotic cardiomyopathy. Then ischemic, not ischemic, dilated cardiomyopathy with less than 35% ejection fractions.
AICD.
Then we put combo device, CRT with D. So many conditions are there where we're using this.
AICD.
But majority of people, they do not agree for this. That's the worst part of it, man. Let me show you a person. This is a father of a doctor who we insisted that he should get for a AICD. And he never agreed with us. डॉक्टर साहब जरूरत क्या है कोई तकलीफ तो है ही नहीं ना. I said used to say tell him I'm sorry he's no more. I used to tell him कि look सब जब तकलीफ होगी तो बताएगी थोड़ी कि AICD लगाना है. Look at this LV function. I hope you can see the slides. Avinash?
Yes, sir.
So let me go to a straightforward three-chamber view. Now look at this slide. This is live recorded raw images. Turbulence.
There is same.
Now you can't see a better answer than this. Can you make it out? Look, in systole, I'll try to hold this picture for you if I'm able to do it. Oh, I can do it. I can do it, man. Just a minute. Now concentrate on this spectrum of ECG out here. Wide QRS complex. Now I'm in diastole. I'm moving to systole. Look, turbulence came mid-systole. So here's a turbulence. I can switch off my colors also. Look, this AML during systole is being sucked into LVOT cavity. Now, this is systole out here. It is sucked into LVOT cavity. If I switch on my colors, look what exactly happens. Turbulence. When this AML is sucked into LVOT cavity, the mitral valve is left behind without anything. AML is gone, so you find mid-systolic MR. Let me go one more frame further. Now you can see lot of turbulence. At the same time, you are getting a mid-systolic MR. You cannot find a better picture than this. And look at, we are ECG gated. We can't say we had gone to diastology. We have not come to level of T wave. Now see when it plays. There cannot be a better example than this in hypertrophic obstructive cardiomyopathy. Patient is fine. There is no problem with the subject, you know. The problem is doctor. Can you see this? AML getting into LVOT. Let me stop for you. This is diastole. I'll go to systole. Now it's beginning. Now see this going into LVOT cavity. So mitral valve is opening one during systole and second during diastole. Now it's come back. Now it's opening up during diastole. So you see two times of the mitral valve opening. Now see carefully. In one cycle, mitral valve is opening two times. Correct? Good. So let me go to archive. Show you DCMP.
Sir, one question regarding HOCM. If
Go ahead.
there is more MR, means ki not mild, moderate, or more severe. It means ki there is a severe HOCM or somewhat.
Now, significant MR means very good LV systolic functions. What is the gradient between LV and LA? How much is the gradient between LV and LA, man?
40.
110 millimeters of mercury. LV is 120, LA is 10. So if a normal contracting LV, you find the gradient like MR would be significant. It would be push. And look at this LV. This LV will not have any significant gradients. I'll show you, like, give me time. We are at tricuspid. Let's go to mitral valve. Look, this patient has got hardly any MR. Do you think MR is mild in this patient? We taught you valves. If you ask me what is the severity of this MR, I'll say severe. Then you're going to question me. How do you say it's severe? because the LV driving force has gone away, is very poorly contracting LV, the LA pressures have gone up. Now my blood pressure, which used to be 120 and LA pressure used to be 10, the gradient used to be 120, 10 millimeters of mercury. Here the LV pressure would be 80 to 90. This LA pressure would be 20. If it's 90, this is 20, the gradient would be only 70. So severity of MR in hypertrophic cardiomyopathy means the LV function are very good.
Not very good.
Correct? Now look at this patient. LV is globally hypokinetic. This is four-chamber view, two-chamber view, anterior and inferior wall. And what you'll find in this patient, you can calculate LV function and then you look for an IVC. Let's look for IVC. Look, IVC is 20. Its collapse is to more than 50%. RA pressure are 5 millimeters or more. So his IVC is not big. But let's look at other factors one by one. This is LA 43 divided body surface area. It's dilated. LA is again index is 23. So more than 22 is dilated. Mild MR, certainly yes. But look, LV is dilated. There is no inherent pathology of mitral valve per se. And you will say mild MR, but I'll say reportingly as mild. But if you really look, this is not mild MR. Because of the poor LV systolic function, raised LA pressure, this should be more than this. We'll assess LA pressures now in this patient. This is pulmonic. Now anybody has got a pen and pencil. E oblique E A 89. So remember E wave 80. This is RV free wall. This is E prime. 80 divided by 4. Septum, it's 20. Then go to lateral wall. Again, it's lateral is 7. 7 plus 4, 11. 11 divided by 2, 5.5. 80 divided by 5.5, 16. So E2 prime ratio is 13.66 average. Even if 13.6 is almost elevated. So E2 prime ratio is between 10 to 14. And then look at the LA volumes. 43 ml.
Raised LAP.
So it's grade 2 diastolic dysfunction with raised LA pressures. By 2016 guidelines. Even if you calculate by 2025 guidelines, it'll be raised LA pressures. So patient has a poor LV systolic function, dilated LA, dilated LV, poor LV systolic function, raised LA pressure, and must be having a significant tricuspid regurgitation. Look, 3.65 and 54. Correct?
Correct.
We showed you dilated. We showed you is now hypertrophic. Now let me show you ischemic cardiomyopathy. What is the difference between dilated and ischemic is you have a wall motion abnormality. Things are same. Now look at this patient. Basal septum is akinetic, mid basal septum. Rest is good contracting. This is not a good picture to show you. Let me just go to a different one. Yeah. Give me a breathing time. It's coming up. Great. Now tell me, what is the issues in this patient? Look, apex is akinetic, is thinned out. Lateral wall is still preserved. This is not thinned out. This is not contracting at all. Let's see two-chamber view. Now you can see very well the anterior wall is contracting well. Apical inferior is gone, and this is contracting well. So when you happen to see a wall motion abnormalities, think of ischemic cardiomyopathy. If you don't see a significant wall motion abnormality, if it is globally reduced, then think of dilated cardiomyopathy. And whatever it is, dilated or ischemic, we always say that we should investigate by doing angiograms. Because if we have a lesion which is viable, if we open them up, LV function will come back to normal. Otherwise, what you'll find? You'll find the same Doppler flow pattern, the same EA ratio, E2 prime septal, E2 prime lateral, then LA volume index. Here, LA would be normal. Despite low ejection fraction, this person will be good. As far as things are concerned, he'll be doing very well. Because the person who has got 25%, suppose this is 45% ejection fractions. His LA pressures are normal, RV pressures are normal, RA pressures are normal, IVC is normal. So he's going to do very well. He'll maybe have an angina in exertion, but he's not breathless. If LA pressures are high, RV, RA pressures are high, it means this patient is going to have a significant breathlessness. Symptoms would be significantly limited. This is ischemic cardiomyopathy. And you may have an ECG changes where you may not see any ischemic changes may not see any ischemic changes in dilated cardiomyopathy. This is what Dr. Rupali was trying to tell you. Heart failure with preserved ejection fraction. Look at the LV function. Tell me what else do you? This patient is a normal sinus rhythm. Look, this E wave, A wave. Correct? What do you see, Rupali, in this patient? Open your mic and let me know. Are you there, Dr. Rupali?
Yes, sir. There is rupture of
Oh, don't tell me. There's nothing like rupture. Tell me about chamber sizes. What do you see in this chamber sizes?
Seems dilated.
dilated, sir.
What dilated?
Array and
LAR.
LA.
LA and RA. Look at the LV. Look at the RV.
LV
They're
is
normal.
also
If the same patient has got a normal sinus rhythm, the same patient become abnormal sinus rhythm, then we'll say abnormal will become immediately, we'll say atrial fibrillation. Correct? Now, what exactly this patient is having now? Now look at E wave. 103, 59, 1.74. Remember 103. Next is E prime, 5. Ratio is 19. Then average is 15.56. LA volumes are 37. So already we have gone to grade 2 diastolic dysfunction with raised LA pressures. And the only thing which is left behind is to look for TR jet velocity. Look at the TR jet, more than 2.85 meters per second. So this patient is classical example for heart failure with preserved ejection fraction. And this is what bullseye we say. Global longitudinal strain is still preserved. And if you leave these people behind, what will happen? They'll go into atrial fibrillations. And this is, believe my words, this is what is seen almost in 50% of populations today. And these populations are nothing. These are the population who are hypertensive, diabetics, obesity, sleep apnea syndrome, aging populations. And there's a full article published in JAG about 22nd July. You can say almost 3 weeks down the line. And the treatment of choice, diuretics is the first line of choice, class 1. Then the 4 more drugs are available. One is dapagliflozin, empagliflozins, MRAs, especially non-steroidal, like that, forget the name. It's a trendy, Finrinon. Then secubitor versatins and like GLP-1 agonist. Amongst all these medicines, I'm sure like over a period of time, these rest of the medicine belong to class 2A. And I'm sure over a period of time, diuretics along with Finrinon would be class 1 indication with heart failure with reserved ejection fractions. And believe my words, this is what we can establish these people having their LA strains. Let me just show you, like this is not at your level, but let me try to show you what exactly the LA strain is. If I've got, yeah, I've got adequate images. So let me measure.
Sir, SGLT2 inhibitors also.
Yes, that's secubitor valsartan, I said, Rupali.
Yes.
So this is what we do in LA strain. 4-chamber view first. So it gives a reservoir strain of 29, 22, 7. On 4-chamber view. So I'll approve and select next one. That is 2-chamber view. I hope the heart rate matches. Now you can see average of this 4-chamber and 2-chamber is 24 is a reservoir strain, -17 and -7 are conduit and contractile strains. Volume index is almost borderline 32. Anything less than 29% is considered as reduced reservoir strains. And these people, there are very high risk of developing a atrial fibrillations. So you can predict atrial fibrillation today. So which patient is going to get into atrial fibrillation tomorrow? Questions? Anything you have in mind for cardiomyopathies? Let me show an example for, let's see. Now you can see this, let me go to 4-chamber view. You can't find a better images than this for amyloidosis. This is a proven amyloidosis. Look at the speckled appearance of the myocardium, both septum and posterior wall. And this is what is there. Look, there's all speckling seen over here. I was looking for a 4-chamber view. Yeah. Can you see this beautiful speckling? As if the light is emitting from these textures. And they have large LA, large RA. LV cavity is becoming smaller in size. The small pericardial effusion. which is a poor prognostic sign. If you develop a pericardial effusion, it means a poor prognostic sign. And what Dr. Hansa was saying, I hope I've got that picture, cherry on the eyes. If it's not, I can calculate it for you. Yeah, I should be able to calculate for you. Can you see this? Oh, it's gone. It'll come back again. This is not a truly pictures, but look, everywhere this is light yellow in color, light pinkish in color, but at the apex, every strain is preserved. Strain is -20, -22, -22, -14, -17, -20. Anything value more than 17 is considered as normal. This pinkish color says strain is reduced. This blue color strain says when these segments are contracting, these segments are relaxed. And this is what is known as classically cherry on the ice. This is not exactly, I can say that, but this is like this red area would be red in color, and this will be more brightened with preserved stain in the apex.
Sir, why apex is spared? Only apex is spared.
That is a classical feature of amyloidosis.
Sir, why and how?
Avinash, you ask me always a question which I'm not able to answer all the times. I'm a basically evidence-based practitioner, but I'm not a researcher. But I'll find it out and let you know. Just give me some time. All right. So this is what is available in cardiomyopathies. Remember, any patients whom you find breathlessness, whom you find pedal edema, always investigate for cardiomyopathies. Always. Pedal edema with breathlessness. Because pedal edema will come only when the patient is in right side heart failure. Breathlessness could come from right side, could come from left hand sides. But as far as things are concerned, thinking of a cardiomyopathy means we have to look for everything. And today there is a very good way of looking at cardiomyopathies is we can differentiate in pedal edema breathless with NT-proBNPs. If NT-proBNP is high, fair chances are we are dealing with heart failure. If NT-proBNP is normal, we are dealing with possibly non-cardiac illness. And there's a range for NT-proBNP. Like 60 to 70, there are almost 900 units are 900 or more is considered as abnormal. So there's a chart for NT-proBNP which you should have in your labs. All right, any other questions before I stop over here? I can go on as long as you want. I have absolutely no issues for me. And there's one more condition which is known as stage B heart failure. We have published a paper recently on stage B heart failure in Indian Heart Journal.
Sir, HOCM can be latent.
Latent means?
Just for example, a patient came with earlier diagnosis, HCM, non-obstructive HOCM.
Right.
After it was diagnosed 2019. After 6 years, means 2026. I diagnosed him HOCM because he has obstructive cardiomyopathy, LV obstruction. Resting was 15 millimeter of mercury, and when I do did Valsalva, it was 64 millimeter of mercury.
Avinash, the problem is like even at that time only, also you may be having some obstruction, but nobody did Valsalva.
Sir, in his report, mentioned that gradient was 8 millimeter of mercury and it was picked up to 18 millimeter of mercury.
So he was a Hokam at that time, but not a classical Hokam. He developed over a period of time because his gradient was less than 25. So they classified him as non-obstructive at the time, but now he's obstructive. Means the gradient developed over a period of time.
Same systolic anterior motion of anterior mitral leaflet was visible clearly, but not so much prominent.
Avinash, if there's a SAM is present, there's no way that he will not have an obstruction. I don't agree with that.
But there was mild lemma like that.
Avinash, like it's all depends how much time you spend with the patient. I don't say like every one of you can, all of us can spend a lot of time, but I only say like when you have a patient which is in doubt, just put him aside, finish your work, then you can utilize him again or give him a toffee to come back again next day. Toffee means some tablet, give him a crocin bloody, half tablet of crocin. Give him a B complex, open up a tablet of B complex, give it to him, boss, just take this tablet, 2 tablets today, tonight, 2 tablets tomorrow morning, come back again, we'll do something more for you. So these people, they need time. Same aortic stenosis, they need time. And when the labs are busy, like everybody's trying to finish our work, they don't do exact work. When you're tired in the evening, do you do a correct echocardiography? You just want to finish your work and go. My intervention cardiologist is very happy number of times with me. Because why he's happy? He always says that, boss, whatever you say, the lesion is always over there. If I tell them RCA, is RCA. If I tell them is mid LED, it's mid LED. If I tell them proximal LED, is a proximal LED. If I tell them left main, it's left main. Then he's telling me, why are other people are not able to tell me like where the lesion is? I said, you have to spend time with the patient. And then on top of that, you have to have a hardware also.
Thank you, sir.
So you have to have everything together to make a good diagnosis. Anyway, forget about that. We'll ask some questions. That's more important. Anybody else? We are almost coming closer to midnight. So anybody else has some questions, or let me just quickly take your attendance. All right, quick attendance. Roll number 1. Gautam Devnath.
Yes, sir.
Good morning.
Sir.
Rahul Sagwan, roll number 2.
Yes, sir.
3.
Present, sir.
4.
Yes, sir.
5.
Present, sir.
6. Dipankar. 7. 8.
Present, sir.
9.
Present, sir.
10.
Present, sir.
11.
Present, sir.
12. 13. 14.
Present, sir.
15. 16.
Present, sir.
17.
Present, sir.
18.
Present, sir.
19.
Present, sir.
20.
Present, sir.
21.
Yes, sir.
22.
Present, sir.
23.
Present, sir.
24.
Present, sir.
25. 26.
Present, sir. 26
27.
present. Yes, sir.
27. 28.
Present, sir.
29.
Present, sir.
30,
Yes, sir.
31,
Present, sir.
32, 33,
Present, sir.
34, 35, 36,
Present, sir.
Yes, sir.
35.
35 present, sir.
All right.
Sir, roll number 6 present, sir.
Roll number 6 present. All right. 37,
Present, sir.
38. All right. Absentees. Roll number 7, 12, 13, 15, 25, 32, 38. Now online alone. Rachel, Monica, Paul, Raghavan, roll number 1 online.
Present, sir.
Good morning, Rachel. Roll number 2,
Present, sir.
roll number 3, 4,
Present, sir.
5,
Present, sir.
6,
Present, sir.
7,
Present, sir.
8, 9,
Present, sir.
10, 11,
Present, sir.
12, 13,
Present, sir.
14, 15,
Present, sir.
16,
Present, sir.
17,
Present, sir.
18. Dr. Jha. Absentees. Roll number 3, 8, 12, 14, and 18. And
प्रेजेंट
last,
सर प्रेजेंट सर
सुनील जी
डॉक्टर
कहाँ थे आप?
सर यही हूँ सर
ओके, मैं तो आपका नाम
क्या
पूछ रहा हूँ.
हाँ सर मैं
आपके यहाँ
यहाँ हूँ
प्रोग्राम ही नहीं हो पाता.
हाँ नहीं मैं बेंगलोर में हूँ सर,
अच्छा, कोई
दिक्कत
बात
हुई
नहीं. नो इश्यूज. अच्छा, लास्ट ईयर डॉक्टर राजन वर्मा,
Present, sir.
डॉक्टर नरेश जंगाड़े, डॉक्टर रक्षपाल सिंह, डॉक्टर अजय जयराम चौरसिया, कमल मालविया,
Present, sir.
and Shabir Ahmed Khan. All right, guys. So let me say thanks to you for bearing with
Sir,
us.
sir, Dr. Channa Reddy present, sir. Sir, sir.
Channa Reddy, कहाँ थे आप? Where were you, Channa?
I network issue, sir. Some.
Oh, you must connect your good network, man.
Sir, roll
Sir.
number 13.
Roll number
How-
12, sir. Nadi.
Done.
Okay,
13
sir.
also done. Dr. Channa, how old are you?
Fine, sir. Sir,
How old are you?
I am 43, sir.
43. Okay, your network is bad, man. You should
Sir.
do a good networking.
Yes, sir.
All right.
My number is 12, sir.
I've done it. Channa, I've done it. Don't worry.
Okay. Thank you, sir.
All right. All right, guys. Next week we'll meet again, and possibly, if everything goes well, we'll have a question answer session and maybe like exam after that. That'll be okay with you.
Okay, sir.
We showed you a live demonstration even today also. We'll show you more live demonstration to clear your doubts. So get ready with question answer sessions. And then possibly we'll have exam any day in between because I have to make up one class. So next week I'll take up question answer sessions and then we'll have a exam between the next Thursday. Between the next Wednesday. Okay. With this word, let me pay thanks to each one and every one of you staying with us over a period of time. Long
sir.
hours, almost 2.5. Good night. Stay safe. Shabba khair. We'll meet again next week.